Hello guys, today we will talking about urology topic and we will talk just about stones or what we can see in the urology system and stones in urology system we call urolithiasis. Urolithiasis, you need know it. Okay. Uh, Calcium-based stones account for the vast majority of all renal calculi, 80-85% of all stones. These are usually due to elevated urinary calcium, uric acid, or oxalate, or decreased urinary citrate, an inhibitor of stone formation. Conditions which lead to hypercalcemia, such as hyperthyroidism, may be causative. However, in many patients, an underlying metabolic defect cannot be identified. Infection stones, or another name of this disease is uh, Struve-White stones. Struve-White stones account for 1/8% of all stones. These stones can grow rapidly and commonly present as a staghorn calculus. Staghorn calculus you can see in the picture. They contain magnesium, ammonium, and phosphate. Urea-splitting organisms such as Proteus, Pseudomonas, and Klebsiella, they produce urease, which catalyzes the conversion of urea into ammonia and carbon dioxide, resulting in alkalinization of the urine and providing an environment conducive to the type of stones formation. Uric acid base, less than 5% of all stones. Risk factors for uric acid stones include diabetes, gout, myeloproliferative disease, rapid weight loss, chemotherapy treatment, hemolytic anemia, and chronic diarrhea. These stones are characteristically radiolucent on X-ray and can be dissolved with urinary alkalinization to a pH above 6 and 5. Uh, Cysteine stones are uncommon. Only one or 2% of all stones. They occur due to a genetic metabolic defect leading to increased urinary cysteine. These patients begin forming stones at a young age and have high recurrence rate and therefore need close observation and medical management for the prevention of stones. Etiology of renal calculi is often multifactorial. Um, for example, dehydration certainly increases the risk of urolithiasis, with a higher incidence of stones being seen in hot, dry climates. Individual patients may also have underlying structural any condition that leads to urine stasis, or metabolic as highlighted above. Disorders that increase the risk of stone formations. Clinical presentation. Non-obstruction intrarenal calculi rarely cause any symptoms and are often detected incidentally on imaging done for other reasons. In contrast, renal colic, perhaps more accurately considered ureteric colic, result in severe pain that has a sudden onset and a typical loin to groin distribution. An acute abdomen must be excluded. Those with renal colic characteristically shift in bed constantly, struggling to get comfortable, in stark contrast to the patient with peritonitis who will be lying very still. Clinical examination in renal colic tends to be rather unremarkable. Patients may have renal angle tenderness but have a soft abdomen with no signs of peritonism. A urinalysis of demonstrates hematuria, but this is not diagnostic as it may be absent and can also be seen in other conditions. If someone presents with renal colic, coexisting urinary infection must also be included as the presence of an infected obstructed kidney is a surgical emergency and mandates urgent drainage of the infected system. The majority, 90% of all renal calculi, radiopaque and can therefore be visualized on plain X-ray. You see it on picture in right side. Many concrements, many stones. For initial diagnosis, however, CT of the kidneys, ureters and bladder non-contrast. What we see in picture some left. Kidney, stones, 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 and bladder. Imaging modality of choice as not only will it identify calculi but also provides helpful information with regard to their anatomical location as well as any associated hydronephrosis indication obstruction. CT intravenous pyelography contrast study including the light phase can be used to delineate the urinary system to differentiate phlebolytes or other external calcification from ureteric calculi. If CT is contraindicated, for example pregnancy, ultrasound may reveal hydronephrosis and can sometimes demonstrate renal calculi. Also, ultrasound has a low sensitivity for detection ureteric calculi. But we in our emergency hospital, we always using ultrasound to have a deep diagnostic with acute abdomen. And when we do ultrasound, we see a small hydronephrosis, and if we see it, we're thinking about a stone. if you see hydronephrosis and hematuria. We will thinking about stones on the urinary system. Laboratories. Patients with renal calculi should have initial metabolic screening with serum urea, creatinine, and electrolytes including calcium, magnesium, phosphate, and uric acid. Urine should also be sent for microscopy and culture and pH evaluation. More formal metabolic testing is indicated in patients with recurrent calculi or other risk factors, and a 24-hour urine collection should be evaluated for pH, volume, calcium oxalate, citrate, and uric acid. This may reveal an underlying metabolic abnormality that can be targeted to prevent future episodes. Management. Many uric calculi can be managed conservatively. The smaller the stone and the more distal, the more likely it will pass spontaneously. Approximately for maybe 70% of stones less than 5 mm in size will pass. Acute renal colic pain is best managed by non-steroidal anti-inflammatory drugs rather than opioids. Medical expulsion therapy with alpha blockers such as tamsulosin is often prescribed to improve rate of spontaneous stone passage. Also, the evidence regarding efficacy is unclear. In patients who elect for conservative management, follow-up imaging to ensure stone passage is important, as symptoms may resolve despite persistence of an obstruction calculus due to auto-regulation of renal blood flow. Patients who fail conservative management after 4-6 weeks warrant surgical intervention to prevent renal impairment. Indications for intervention include infection, obstruction in a solitary kidney, bilateral obstruction, and uncontrolled pain. In the setting of an infected obstructed kidney, resuscitation, antibiotics, and urgent drainage of the collection system should be undertaken. Decompression can be achieved either by cystoscopic insertion of a ureteric stent or radiological insertion of a nephrostomy tube. Once the sepsis has been adequately treated, definitive stone treatment is undertaken on an elective basis. Non-obstruction intrarenal stones do not always require treatment depending on size and associated symptoms. The risk of asymptomatic episodes for small non-obstruction renal calculi is 10–25% per year. However, all staghorn calculi should be treated, as they may lead to progressive renal damage and infection if left. Indications for treating smaller intrarenal stones include infections, symptoms, for example pain or hematuria, patient preference stones larger than 5 mm, high-risk stone formers and social circumstances that would make seeking future medical attention difficult should an emergency arise. Definitive stone treatment depends on the size, location, and composition, if of course you know it. Large intrarenal calculi are best managed with percutaneous nephrolithotomy. Small ureteric or renal calculi may be managed with ureteroscopy, pieloscopy, and stone fragmentation, as high, high, hmm, highlighted earlier. Some stones may be amenable to dissolution therapy. All stones forms should be given general dietary advice to increase oral fluid intake, decrease sodium and meat intake, and have a moderate calcium intake. If a metabolic defect is isolated, treatment should be targeted at correction of his. That's all about stones of uterus or urinary system. If you have any question, you can write downstairs and join me in Instagram. Bye bye.